Hello and welcome to the event we've all been waiting for, the Lutronic Ultra Virtual User Summit, moderated by Dr. Joel Cohen and featuring panelists Dr. Bradley Bloom, Dr. Arash Morazadeh, Dr. Emil Tangeti, and Dr. Amy Taub. We are extremely excited for you to join us this evening for a program packed full of education and discussion on how to maximize the potential of your Ultra system. At Lutronic, we appreciate our customers' loyalty, and we wish to support you in every way possible through educational opportunities such as this one. Tonight, you will be hearing from some of the world's top 1927 nanometer thulium experts as they discuss real cases from their portfolios. Protocols, settings, treatment pearls, and lessons learned will all be addressed. This formal program will last approximately 90 minutes and will be followed by a question and answer session, as well as questions being addressed throughout each panelist's presentation. Type your questions into the Q&A box at any time. The panel will address as many as possible, but due to tonight's record-breaking attendance, we may not get to every one of your questions. Please don't worry, you'll have an opportunity to submit additional questions at the end of the evening, and a Lutronic representative will follow up with you. This session will be recorded and made available to our customers very soon. You'll meet all the panelists shortly, but without further ado, please allow me to introduce our esteemed moderator, Dr. Joel L. Cohen. He's the director of About Skin Dermatology and Derm Surgery in Colorado. He was named a top dermatologist by the U.S. News and World Report, Castle Connolly Regional Top Doctor, and voted by his peers as one of Denver's top doctors in 5280 magazine 9 times. He is a board-certified dermatologist, fellowship trained in Mohs surgery, lasers, and cosmetic dermatology. Dr. Cohen lectures regularly at both national and international meetings and participates in many clinical trials. Dr. Cohen was elected to serve as a national instructor in dermatologic surgical and aesthetic procedures by the American Society of Dermatologic Surgery, ASDS, as well as the American Society of Lasers in Medicine and Surgery, ASLMS. He serves on the teaching faculty of the Department of Dermatology at University of California, Irvine as an associate professor, and as a fellowship co-director for the ASDS Dermatologic Surgery Colorado Fellowship. In 2018, he received the Melanoma Research Foundation Humanitarian of the Year Award. He has also been the recipient of the ASDS Public Service Award, the ASCDAS Distinguished Service Award, the ASDS Traveling Mentorship and Teaching Award, and the ASDS Excellent in Education Award. He's been a recipient of the Patient's Choice Award from 2010 to 2019. Dr. Cohen has proudly published over 255 medical articles and book chapters. He has co-authored 3 academic textbooks. He has been quoted in many newspapers and magazines, including Time, Glamour, Allure, the New York Times 3 times, Red Book, Shape, USA Today, U.S. News and World Report, Marie Claire, Vogue, Cooking Light, InStyle, BuzzFeed, MSN.com, ABC.com, New Beauty, Condé Nast, Men's Health, Huffington Post, the International Business Times, Self, Consumer Reports 6 times, Women's Health, and More magazine. He regularly appears on Denver TV stations with over 75 appearances discussing aesthetic issues, dermatology, and skin cancer, and is a frequent guest on SiriusXM Doctor Radio. He was also featured on the Emmy Award-winning show, The Doctors. We are truly honored and very lucky to have him here running the show this evening. And with that, I will turn the session over to Dr. Cohen. Please take it away, sir.
Thank you very much, Dan. Dan, thank you very much for your hard work in putting this together, along with Gina and the folks from Lutronic. It's great to hear that we have record-breaking attendance for everybody. So I'm going to be discussing my experience with using LACE MD and then Lutronic's Ultra. And then Bradley Bloom from New York City is going to be discussing really how he decided to really integrate Ultra into his practice. Arash Morazadeh is going to be really focusing on integrating LACE Ultra into his surgical practice. And then Emil Tangeti, who always dazzles us with histology and high-level academic stuff, is going to be talking a lot about the histology and what's actually going on in the skin when we're using Ultra. And then Amy Taub does always a fantastic job integrating topical products into her laser treatments and that combination therapy. And she's really going to be focusing on laser-assisted drug delivery with Keralace, something that she's been very involved with over the years, and she practices in Chicago. So, you know, if we look at Ultra and we look at where this positions in terms of the rest of the marketplace. First of all, this is the highest power 1927 device tied with the Moxie from Cyton, but it has significantly more power than the Dual and the Clear and Brilliant. And so this is a 20-watt device. In terms of consumables, this has the lowest cost across the platforms for consumables for 1927. It's $22 per patient. If we look at what else this gives us, number 5 is really the option of integrating laser-assisted drug delivery. In my practice, we use a lot of tranexamic acid. You can also use the vitamin C and A formulation, or the resveratrol, or what Dr. Taub is going to focus on as far as the Keralase. I think you will find, if you have the Lace MD or the Ultra, that these are very, very comfortable procedures. It's really a grade 2 out of 10 discomfort for almost all areas. I think when we get to the cheekbone, maybe it's a 3 or 4, upper lip, maybe a 3 or 4. But in general, it's a very, very well-tolerated procedure with very minimal downtime. People are usually pink for a couple days and a little bit dry for a few days. And you can use it across all skin types. And I think we all have experience doing this. And, consistent with Lutronic, this is a unique, smart system. So really, it dials in to maximize your power when you set in your millijoule setting. And we'll see that with some videos of us doing the procedure. So there's a low consumable cost. As I said, it's about $22 for the consumable. You can treat any skin type. People really report very minimal discomfort at all, 2 out of 10. And this is very effective for overall, for photo damage and for pigment, and for the approval as far as soft tissue coagulation. In terms of other things to think about, when you think of the histology here, so 1927 is on the left, and it is a non-ablative laser, and that's actually the superficial, really, histology of it. Coagulation is observed in the epidermis and the dermis, and if we compare this to 1540, 1550, even the 1440 that many of us have in the office, this is something that's very different in terms of 1927, because it's not going as deep as the other one. So there is less downtime with the 1927, pain is less, and there's less issue in terms of really going deep, stacking up those pulses and heating and potential for pigment alteration. So this is really something that you can modulate your downtime and really have low downtime, and you can have really effective results as well. If you want to compare this to erbium resurfacing, I do a lot of erbium resurfacing. This histology is really looking at fractional erbium, and that's really full disruption and ablation going down into the dermis. This has quite a bit of downtime. There's not the coagulation that you see here on the right screen with CO2 in this area, where you can see all the change in the color to this more purple area, but that also has longer downtime. So with the 1927 and the Lace MD, this is non-ablative resurfacing for all skin types. You can treat all patients all year round. I live in Denver, Colorado. There's over 300 days of sunshine a year, and this is something where I feel comfortable treating people on an everyday basis. You can really customize it to really low energies as well as to high treatment intensities. Some of the people I use really low energies are people with melasma. I'm concerned about heat. I just do a low energy, low number of passes, and I oftentimes integrate the tranexamic acid. And people really like the fact that this is sort of a spa-like treatment in many cases, because it's quick. It's not something really painful. They don't have to go through a whole block experience. They certainly don't need Pronox or anything like that. So if you look at specifically the cleared indications, this is indicated for soft tissue coagulation as well as benign pigmented lesions such as lentiginous, which are age spots, and epiblids, which are freckles. But interestingly, it's also FDA cleared for actinic keratosis, precancer lesions. So, for people who are interested in this from a cosmetic standpoint, there is a medical reason to use this as well. And it is something that a lot of my patients do for that very reason. So I spend my time doing lasers and aesthetics for most of my time, and then some Mohs surgery as well. And many of my skin cancer patients have become ultra patients as well, just because it's that sweet spot. It has the clearance for actinic keratosis. And in some cases, these people may do topicals like imiquimod or 5-FU. In some cases, they may do photodynamic therapy, but not everybody wants the downtime and that unsightly appearance of the redness and the swelling that you have with those treatments. And as I said, with this one, it's very minimal downtime. You can have a slight pink response for a couple days. So this is really me doing the overall treatment. I'll familiarize you with the platform, and I'm going to start the video here.
The LACE MD Ultra has been a great addition to our practice. For about a year and a half, we had the LACE MD, and this really is allowing us more energy, faster treatments, and I think it's a great piece of equipment in terms of overall efficacy and uniformly treating areas of pigmentation, and really see great results for overall photo damage, pigmentation, light reflection on the skin, smoothness, and it's FDA cleared for actinic keratosis.
So one of the things that I typically do in my practice is combine this with the Spectra, which is the Q-Switch 532.
The LACE MD Ultra has been a great addition to our practice.
Which is Q-Switch 532 and Q-Switch 1064. And that's what I did here. So you can see the Q-Switch Spectra on the far right next to my assistant Lindsay over there. And that's something that we've had in our practice that's really been a staple in our practice. We use on an everyday basis. It's a Lutronic piece of equipment. We do the carbon toning for people just for overall toning of the skin. It seems to help people with acne. We use it for lentigines, and we use it for acne as well. And this is a really nice complement to using the Ultra, because I hit the individual lesions with the Spectra first, and then I go ahead and I do the Ultra, which is exactly what I did here. And we'll show you really what the Ultra looks like. This video is a little bit sped up, but this is a very, very quick and efficient treatment that's not painful. You can look at the patient and really see her experience.
The erythema on her cheeks and the area of a little pigment darkening and a little bit of swelling. We just completed the Q-Switch 532 Spectra to these isolated low contrast lentigines. And now we're going to do the LACE MD Ultra Thulium 1927 throughout the face. She's all set. That's 8 passes at 14.
So if people have the LACE MD and they're thinking about switching to the quicker, more efficient, more powerful Ultra, then really the change and exchange that we do is I usually go down about 3 millijoules. So, you know, if I was at 17 millijoules with the LACE MD Ultra, I'll go down to about 14, and anywhere from 8 to 10, sometimes 12 passes, really depending on things. And, you know, you can actually also do, you can do really a combination of using static mode as well as the general mode. So the random mode is what most people do to treat, but the static mode is just on individual lesions. So this is a patient who started treatment just before the pandemic and then finished over the summer. So she got a bit more sun than expected, but you can see this is just a couple treatments, usually spaced about a month apart. And you can see that these people have had pretty nice improvement in overall focal areas. This was just standalone treatment with the Ultra. So just the Ultra itself. And, you know, oftentimes, as I said, even on the chest, I will integrate the Spectra. So
what were you hoping the treatments with Lutronic Ultra would help you with?
I was hoping that the treatments would get rid of a lot of sun damage that I have on my chest, dark spots, lightening them up, and then in general, giving me the skin like a less crepey quality.
Has Lutronic Ultra helped you with these issues?
It has helped. So the sunspots and sun damage that I had has lightened significantly, and I think that the skin looks healthier and firmer.
And what are the greatest benefits you've received from Lutronic Ultra?
The greatest benefit would be the lightening of the sun damage, so the skin being lighter in general and those spots dissipating, and in some cases being gone altogether.
And why would you recommend Lutronic Ultra?
I would recommend it because there's no downtime. Essentially, you get kind of a sunburn quality for about 5 to 6 hours afterwards. So I think downtime for me was a huge benefit. And then the second reason would be that there's very little discomfort. So with the numbing cream, there's very little discomfort once you, while you're in the treatment.
Okay. And why would you recommend Lutronic Ultra to someone who might be on the fence?
I would recommend this procedure because it was for someone who has sun damage that bothers them, especially in an area here where in the summer you see it a lot. I think that I'm so much happier that that area now has less sun damage and is.
What are the greatest?
So, you know, as you can see that people with just a couple treatments, this is 2 treatments, they will see improvement in the pigment. They speak to the fact that there is very little downtime just for several hours, very little discomfort. And it is something that they really are willing to talk about their experience. You know, if you compare it to something like IPL, you know, this is something that's going to get texture as well and smoothness. And again, this is approved for actinic keratosis. And here's another characterization from another patient.
I think it made my chest area look better and it got rid of some of the spots and it was easy.
Why would you recommend Bluetronic Ultra?
For those last reasons I just said. Number one, it was very easy. It was an easy thing to do and it got rid of a lot of the old age spots and it cleared up my chest a bit.
Why would you recommend Bluetronic Ultra to someone who might be on the fence?
Just easy. And I think that it does what it's supposed to do. So you can see a noticeable difference. In my pictures, I definitely see a noticeable difference.
So, you know, I think that there's been an opportunity for us all to talk about some of the things that we do in the office in different avenues. In New Beauty, I'm on the medical board. I spoke about the Lace MD and then subsequently the Ultra, but I put this up because oftentimes in our practice, we're combining it with the Genius and the radio frequency from Lutronic as well. So it really makes sense to do the Genius first to really hit some of the laxity and then do the Ultra over it. So some of the patterning that you can see, especially on the neck from the Genius is something that you can really go over with the Ultra so that you don't see as much of it. And it's pretty dramatic, right? When you finish a treatment with the Genius, you definitely see that patterning, you see some pinpoint bleeding. And then when you go over that with the Ultra, immediately you'll see sort of those areas blend out. So I think it makes it a lot easier for patients to do that sort of combination where you're helping some of the laxity and the coagulation of that, and you're also at the same time helping pigment and smoothness and light reflection. It's really a nice combination that we do in our practice. So Consumer Reports a couple months ago in July, I talked about really just my experience using the thulium laser, in particular the Lutronic Ultra, and from specifically other standpoints, the minimal discomfort that you have and the fact that it is approved for actinic keratosis really stands apart from other types of modalities. And then a few months ago, I had Vic Ross and Eris Diane talking about radio frequency and on Scientifically Speaking, and I really talked a lot about this combination. And you can see Vic Ross talking about radio frequency and penetration of the skin and the Genius in that area, but really complementing that with a way to address texture is really important as well. So, you know, my experience with Ultra has been very, very beneficial for my patients. I think the minimal downtime, the minimal pain, and the fact that you can really see improvement with each treatment without having discomfort and downtime of pigmentation, of smoothness to the skin, of overall photo damage, and precancers. And then you can go from that random mode to the static mode and really work on individual spots has been really helpful. And, you know, I think, you know, from the experience of how do you choose integrating Ultra into your practice versus other 1927 devices that are out there. As I said, there's Moxie out there, and then there's the ones that are less powerful in terms of the Fraxel Dual. And then we have the Clear and Brilliant as well. So, you know, it's important to really think about these things. And I'm going to turn things over to dermatologist from New York, Dr. Bradley Bloom, to talk about his experience.
Joel, thanks so much for the introduction. And it's a pleasure to be here, certainly with an amazing panel. This is a pretty easy talk for me to give because I've had quite a bit of experience with the device, and certainly its earlier iterations into currently it's finally the Ultra today. And I really enjoy using it. I'm a dermatologist. I practice in Manhattan, and I also perform Mohs surgery, and so I have quite a bit of experience with a number of different 1927 devices. But this now has become a very, very common procedure I do in the office, and I think my patients are really appreciative of it. So I can set that next slide. So when I first started using the device was years ago with the original LaserMD. I was part of some clinical trials that were done, and these are photos from a clinical trial that was presented at the ASLM's actually it was the 2019 meeting, and you can see it was a study where we used the LaserMD, and patients who had melasma had 5 treatments with an interval somewhere between 3 and 4 weeks. And after each treatment, immediately the topical Tranexamic Acid 1.2% solution was applied, and then subsequently for twice a day for 7 days. And you can see that at 90-day follow-up after the treatments, there was a 31% improvement in their MASI scores, which is quite impactful. We all know that melasma is incredibly difficult to treat, right? None of these procedures ever cure melasma, but they dramatically improve the appearance. And we included in these trials some people who had pretty significant melasma, and you can see here pre-treatment and a 30-day follow-up, dramatic improvement, and certainly she was very pleased. The one thing that I would say about the device that I feel very comfortable treating melasma with this device, when you use the correct settings, you can treat darker skin types, and you can even treat patients with melasma. And I think that there aren't that many devices where I feel very comfortable saying, oh, you're not going to make it worse. And I feel very comfortable with the appropriate settings that you can do a great job in improving melasma. Go to the next slide. So here's the same patient, just the other side of the face, and you can see this is a significant improvement. And she'll continue to improve, especially with photo protection. So I think that it's a really nice thing to offer our patients. Can I have the next slide again? So this is a patient of mine, and I'm sorry for the saturation in the difference in saturation in the photos, but you can obviously tell this is a patient who had one particular stubborn area of melasma in the glabella, and that can be quite disruptive to the aesthetic because it's right in the center of the face. And here you can see I used the Lutronic Ultra, and I used just a single treatment, multi-pass technique in the random pattern. And she had dramatic improvement. I didn't add any additional topicals. She had been on topicals for months, but just wasn't getting to the point where she was happy, where she was pleased. And you can see pretty dramatic improvement. And so, I think it's relevant to ask, why the Ultra versus any other 1927, because there are other devices out there. And so I thought that I would mention a few things that I like about this device. And what I really like about this device is the versatility. So what they've done with the Ultra in its most current iteration, they've increased the power of the system, and that allows you to do many things that are sometimes hard to understand. But one is it allows us to control the amount of power and energy separately. It allows us to treat at higher energies, but also allows us to do treatments more quickly. There are multiple modes in the system, so you can use a dynamic mode, a random mode, static mode. There are all these different options that allow us to customize treatments, individualize them for patients, and it allows us to treat all skin types. And that's a huge deal, especially when we have such diverse populations, particularly in New York City. The other thing that I like about this system, which I was surprised that I didn't realize how much I would appreciate, was the magnetic rolling tracking system. So a lot of the other devices that have a rolling system, which I do like to do because it really creates a very random array pattern on the skin, use an optical tracking system. And sometimes those optical tracking systems can be a little bit fussy depending on the patient's skin type. Whereas these magnetic rollers, what they do is there's a magnet inside the two rolling tips, and it actually processes every turn, every rotation, every revolution of the roller, which represents the movement across the skin. And I think that allows you to give very, very consistent delivery of each of these microscopic thermal zones for a very nice even effect. But so it's a pleasure to use, and I think it's been a great addition to the practice.
So Thank you very much, Bradley. We have a few questions, and I think, we touched on some of this, but I'm going to ask you specifically. One was really about the safety of type 5 and 6 skin, or even potentially mildly tan skin when you're doing the Lutronic Ultra treatment. So if you want to tackle that one first.
So I feel very comfortable treating skin types 5 with this device. I don't have that many patients with skin type 6 coming in with specific complaints that I think would need this. I think that you can use it safely in someone that dark, but there'd have to be I would really want to think about what the indication is. But certainly I feel completely comfortable treating skin types 5. I've treated many. You have to adjust your parameters, and you want to avoid bulk heating. So you want to allow sufficient time between each pass for the skin to cool to allow it for you to be safe. And then the question about being tan, I like to avoid treating patients when they're tan. They're for a number of reasons. One is for safety, but two, if someone's trying to optimize the benefit of their procedure, you want them to be the least tan that they can be, so they can have the best results, then the most long-lasting result of the procedure. So it's more than anything else, I try and avoid doing it on people who are actively tan because I want them to have their longest lasting result. That said, I live in Manhattan, but Arash is going to be talking next, and certainly Emil. They're in California, and patients are chronically bronzed, and they use the device all the time. So certainly you can treat it in patients who have kind of chronic bronze skin.
And I think this is a great point if Dr. Tengetti can jump in, because really a lot of us for many years have relied on his experience and guidance in terms of safe settings for people in those scenarios. With this specific device, similar to other devices, my rule of thumb is with type 4 skin, I usually go down about 10%, type 5, 15%, and type 6, I have a staff member that we treat about 20%. So I think those are things to really think about. If we're treating overall photo damage and people who want their skin to feel smoother, when we get to melasma, I really turn it way down. So the next question is really about melasma. So I do lower density, treatments in terms of overall power settings. Oftentimes I'm about 9 or 10 joules, and I'll only do about 6 passes, and then I'll oftentimes pair this with tranexamic acid, because heat is a factor for melasma. And I think we're seeing some issues with melasma right now with people being on formats like this and Zoom calls and video conferences from blue light. So I think it's an important thing to talk about with melasma, and talk about also to filter blue light. So Brad, if you could talk about your experience with melasma, the types of settings that you use, and then maybe we'll have Dr. Tengetti jump in there as well.
So I agree with you completely. I think when you're treating melasma, you have to be incredibly cautious not to deposit too much energy. And so that's where I actually think the counter here, where you actually are monitoring the total energy delivered, can be incredibly useful. I will use, when I'm treating melasma, I'll typically treat in a random mode, and I'll actually drop the energy down sometimes as low as 5 millijoules. And the number of passes I do will be based on the skin reaction. Some people have a more robust skin reaction, and that produces more erythema or redness. And in those cases, I like to be more cautious and more judicious in the number of passes, because again, I think depositing too much heat in an area can potentially make melasma worse, and that's obviously the last thing we want to do. So I think doing a low energy treatment with relatively low density is important, and I'd rather treat someone more times and not make them worse than try and do something that's overly aggressive and make a problem.
So, and tranexamic acid is something, from a standpoint of interest, people have talked about for pigment issues orally. And, an important screening question for those patients is, have they ever had any blood clots or hypercoagulable conditions? I just want to point out from the Lutronic database, there hasn't been any adverse reactions that are reported. We use this as a laser-assisted drug delivery, so topically applying it with that little vortex, which takes about 6 minutes to mix in. the formulation of tranexamic acid and then applying it after treatment for many of these melasma or significant pigment patients. And, you know, really it was designed to penetrate the skin. And if you have other tranexamic acid topical formulations that are out there, many people compound these things. It's important to note that, you know, what you put on the surface of the skin may not be tested or appropriate to put into laser assisted drug delivery. And I personally have seen some people who've had sort of a granulomatous response to creams and lotions that were really designed for topical use that were facilitated with laser penetration. So can you talk to us about your experience with this tranexamic acid that was designed by Lutronic to apply in conjunction with the laser procedure?
You know, I think that's another great point. I think whenever we're using something to apply on the skin after a laser procedure, any laser procedure will enhance the uptake of what you apply to the skin because of some transient disruption of the barrier function of the skin. So you have to think about what you're applying. You have to be really thoughtful. You know, people don't realize that there are all kinds of excipients in the vehicle or the thing that carries the medication in a topical agent. And so those things are not necessarily intended to be deposited deeper into the skin. And so if you're doing a laser procedure and you're applying something, all the other things that go with the active ingredient will also be increased in penetration. So you have to be careful. And that's where it's really nice to have a system that actually you can have a topical that is designed intentionally to go into the skin. So they've excluded things that would make trouble, because there certainly are things that you would not want to put on the skin that would have enhanced uptake. And the cases that you're talking about have been published in the dermatologic surgery journals, and they're really clear. You know, you have to be thoughtful about what you're applying, and that's where Lutronic has provided you something to make you feel comfortable and safe doing it, because it's intended to be done that way.
So before we switch over to Arash, I just want to have Dr. Tengetti comment on really the energy settings and darker skin types as well from his experience.
Well, you know, to be candid with you, I don't have many people that we put in the trial with a skin type 6, so I really can't comment on skin type 6. But the darker skin types, I think this is a safe treatment. We haven't seen any problem. Asian patients in particular. You know, in Asia, they're very worried about PIH. I haven't seen any of it in our patients. So again, I feel very comfortable, and that's up with the 20 millijoules as well. Now, as you all suggested, melasma is a totally different story. I think we have to be careful. We try to cool the patient actually with the Zimmer as we're doing the treatment. We like adjunctive cooling. We are inclined to use less energy, somewhere between 5 and 10 millijoules. And again, what you'll see at 5 millijoules is some vacuolization at the DE junction. As you're about to 10, you start to dehydrate the whole epidermis. What you do by increasing the energy is you just create more dermal wounding. So again, I think that we try to minimize our settings and try to be carefully, and then, but understand if you're trying to hit a home run and trying to be more aggressive, you're more likely to have a problem. I certainly think that we also have to get someone on a regime that's going to be there daily after their treatment, because even if you put a product on that gets in the skin and is facilitated by the device procedure, it's going to last for a limited period of time. So using something on a daily basis, I think is certainly worth the thought. I wish we had more data on tranexamic acid and its optimization on how to do this. But again, I think using common sense makes a lot of sense to basically use these all in concert with the treatments that work and try not to be overly aggressive. Thanks.
Dr. Amy Taub has been very involved with the topical formulations that were designed. She's going to spend some time speaking about that in Carolase. But Amy, can you comment on the tranexamic acid? Because I think that there is a lot of interest in this as something that is an additional add-on that can really help treat pigmentation, especially melasma.
Yes, I want to point out one thing, and that is that tranexamic acid is not well absorbed through the epidermis at all. So although it's in a lot of products that you can purchase, it's dubious what it's really helping with because of the lack of absorption. So creating channels through which you can absorb it is very helpful. Certainly, the other thing that's important to note is that it's sterile. You know, it comes in a sterile vial. And again, when we're applying things after we've kind of quote unquote opened the skin, we want to know that what's being applied to the surface of the skin has been maximized for skin that where it might go into the dermis. I think it's really ingenious, that little shaker. We put it on at the beginning of the treatment, and it shakes it up. The other thing is there's enough to give to the patient to take home. So you put on, you saturate the face, and then you apply it, you give them the rest and tell them to use it a couple times a day. And who knows if it's helping? We don't really know, but of course patients love to be able to take something home and make, and take it home. And I think tranexamic acid is going to be something that's very interesting. I've thought about using it because we know that the main thing, although we're using it for pigment, we know what it really does is it affects the vasculature. So possibly it could be like a post-treatment regimen to reduce erythema or reduce inflammation. I don't know, but it was something that crossed my mind. So it may be something that we're going to use for more than melasma. And we're working on, full disclosure, I'm co-founder of a company called Skin Query, and we've been working on some of these formulations, but we're looking to create some new formulations that will be kind of an add-on that aren't very expensive, that will enhance your treatment, because after all, we know that combination treatments are really the best.
So a lot of people on this call work in practices that have a surgical component as well. And Arash is going to start, and he's going to really just tell us about his experience in using this in his facial plastic surgery practice in Beverly Hills, and really how you can integrate this into a surgical practice as well.
Hi, thanks for having me. So originally when I purchased the Ultra, my intention was to have something to manage my darker skin patients and all of my melasma patients. I have a lot of patients that are international from Asia and Middle East, and melasma is a big thing here in California, and everyone's tan. So that was my original reason why I purchased the device. But it turns out that I ended up using it even more for so many other things. It's kind of like a treatment that I layer on almost any other device that I'm using, most commonly with Genius radiofrequency microneedling. But I pair it with post-operative cases to improve skin texture. I'm using it on my patients who are my young, naive patients who want pre-rejuvenation. So my 20-year-olds are using it in a way to improve their pores and surface and texture. And then I have those with acne scars, hyperpigmentation, melasma, or combining it with radiofrequency microneedling, facelifting, and other procedures to kind of cover the full spectrum and give them that inside out kind of approach to their skincare. Touching on the melasma topic that we were just on, I agree with the rest of the panel. I tend to stick with the 5 to 8 jewel setting, and I definitely use the tranexamic acid with it. But I think the best addition that I've made to my practice was buying a Cryo 6. By using the Cryo 6 at the same time as your treatment, you're cooling the skin and avoiding some of that bulk heating issue. So better for your melasma patients, but also it makes the treatment so pain-free. So I don't even use numbing cream anymore. We just use straight Cryo 6. Even if I'm doing a treatment on 20 joules, which is the highest setting, we're still just using Cryo 6, and most people don't even need numbing cream. So numbing cream is now almost exclusively more for my actors and actresses who don't want to feel a thing, but everyone else is using that. How do I advance the slide? Okay, there we go. So here is a case that I want to share with you guys. And this is just 1 month after one session. We did 4 passes, very conservative approach. She's 51 years old. Her issues are acne scarring, which is superficial in her case, and as well as significant textural issues and some adult onset acne problems that continue to flare, as well as fine lines. And this is actually my office manager. So it's great to, when you first get a device, to definitely do treatments on people who work in your office and your friends and family, because you want to quickly be able to show your patients how great it is. And they're talking to all of your clients and can really be a good ambassador for the improvements that you can see. She noticed a big change even in her upper eyelid skin. I do treat the eyelid skin as well when I'm doing it. I find that it does help rejuvenate and get a little bit of that crepe out of that area, but definitely improves the overall skin texture. She wears less makeup than she used to. Every patient that walks in always asks, what is she doing? And they notice the change. So it's actually a very big difference, more than what the picture shows. I have a tendency to pair it with skincare regimens. So for example, in her case, we used the Tranexamic Acid immediately after the treatment. And then I had her start on TNS A+ from Skin Medica as part of the post-care regimen in her case. And I think we're getting a nice, good result with it. And then we did a second treatment now to get things going even further. First treatment, I go with a more conservative setting. And then the second treatment, I may ramp it up from there. So this is a patient of mine who came in with very substantial amount of acne scarring, some of them deep, some of them superficial. She hyperpigments very easily. A bug bite, a slight scratch, anything turns into a hyperpigmented scar on her. She keloids and has tons of keloids all over her body. So it was actually a very complicated case, and another plastic surgeon actually sent her to me before he was gonna cut out anything and said, you have all these machines, can you come up with a protocol to help her? So what we did is we did it, first treatment was total skin, which is what you guys are seeing here. So we treated her with, I pre-treated her, in this case, I pre-treated her with the bleaching cream since she has this history of post-inflammatory hyperpigmentation. So pre-treated her for 3 weeks with bleaching cream. She stopped it for 1 week. And then we did the Genius treatment on all of her skin of her face and neck. And then I did on the darkest spots, I used the stamping handpiece from the Ultra at like 15 joules and stamped on some of the select brown spots. And then I used the roller to go over all of the skin one more time. She came back a month later and she's ecstatic. Though what you see on her forehead where there's new brown lesions, that's she got a couple of pimples in the recovery period. And so those are those brown spots, but you can really see it in her chin especially, and I'll show you under her neck. She has very substantial improvements. And this is where you can really see under that chin, that was actually like a scar, and it's already started to really smooth out and the pigment has been reduced. And for her second treatment, which was on this day that you're seeing this photo, we actually opted to go with the stamping and rolling Ultra only. We didn't use the Genius on the second treatment. So we did Ultra only on the second one, continuing with her skincare protocol. And then we're gonna decide on what we wanna do, if we wanna do another round of the two of them together to kind of finalize her treatment. We also started to do a little bit of a trial on some of her keloids on her shoulder. We selected one keloid, a couple of keloids on her shoulder and treated those as well with Genius, but then did erbium laser resurfacing with that and Canalog at the same time. So we're kind of assessing what happens with a couple of those before we continue to treat them. All right. So for the next patient, so this really just kind of like highlights everything you can do with Ultra. So Keratosis is a great treatment. So with both the rolling tip as well as the comb tip, which is specifically designed to treat the scalp, it gives you a nice treatment option for treating hair loss. So there are two ways that I do it. On some patients, I do 3 treatments, normally spaced 1 month apart, and they do at-home care with it. So some of my patients will use the Kerafactor, growth factor at home, as well as their conditioning treatment. And in those cases, they do 3. And then I have other patients who don't do anything at home. And every 2 weeks, we'll do a treatment, and we'll do a total of 6 treatments with Keratosis. So the way that I do it is I most commonly use the rolling handpiece, and I set the setting at 5 joules and roll it over the scalp in the areas of interest until about 4 passes, and you want to see a little bit of redness. If they say that it's painful, then you want to drop it down because that means they need less energy, and then you can do a setting of 4 joules. And then you treat the area. You don't want to transect the hair. You're moving the hair out of the way as you're going. And then you apply the Kerafactor, growth factor product. And in this case, you're seeing after 3 treatments, the results that are seen here. This patient's going to do a full session of 6. So this is pretty impressive hair improvement, especially in that crown area where it's very hard to get hair back with really, really nice results. I do this on all ages, males, females. I have some patients that I've done hair transplant on that want to do this now in their crown because they don't want to do another hair transplant for that area. And we're seeing nice results. I've had patients who had said they had had PRP treatments elsewhere that it either failed or caused more hair loss, that are scared of it. And they come in and we have done Keratosis treatments on them with much success. And the next, yes.
Go ahead.
This is just another case just highlighting the same concept. 60-year-old female with advanced hair loss that I've known for a long time that has tried many things that have failed. And here she is after her 6 sessions with substantial improvement in her hair loss. All of her friends, incidentally, are the ones who noticed a big change, and they have all come in, or their sons, sending in their sons with early hair loss for treatments now.
So before we switch over to Dr. Tangeti Arash, I wonder if you can comment. You know, you had some really nice results with post-inflammatory hyperpigmentation in areas where clearly this patient has had some acne and looks to be a picker. You know,
yeah, she is a picker.
So, you know, I think that this is one area where Ultra in my practice has been really helpful as well. First of all, you know, as with any fractional laser, I tell people to make sure that they're using non-comedogenic products after the procedure. However, even with non-comedogenic products, there's been other fractional lasers, in particular, the ones that go deeper, 1540, 1550, et cetera. But because of the penetration and I think the occlusion, I have seen some acne flares. And I think because the heat is so superficial, and maybe Dr. Tangeti and Dr. Taub can comment on this, and Brad as well, you know, in terms of, I haven't seen that type of acne flare. So I think it's the superficial nature of it, and I think it's the heat of it. But you've had some really nice results with that. So, you know, has anybody else seen sort of really a nice response with post-inflammatory hyperpigmentation and acne, sans acne flare afterwards, or had another experience? Amy?
Yeah, I have not seen any acne flares with this. I believe that I have seen acne flares with Genius though, because when you start going down to 1.5 or 2 millimeters, I think you're piercing through the sebaceous gland, and then you get a little leakage there, and that's what causes the inflammation. I definitely think that this is great for any kind of pigmentation. I've used it for PIH, you know, if it's superficial PIH. This is 1927 is a wonderful modality. And as he's showing here, especially in skin of color, because there's really no, the chromophore is water. So as long as you don't bulk heat the skin and you stay relatively, you know, so you're not too aggressive with too many passes, you're going to get remodeling of the skin, and you're going to lose some of the pigmentation that is basically excess pigmentation in the epidermis.
Emil, and then Brad, what do you think in terms of acne flares after Ultra, or really improvement overall in people who have acne and have post-inflammatory pigment?
I mean, we've certainly seen it with other non-ablative treatments, and I quite agree. We haven't seen it much with the Ultra. I don't think we see the degree of swelling that we see with the other treatments. I think the epidermal and dermal swelling that we see, and when that's marked, it often plugs the follicular orifices up and causes an acne flare, or even a folliculitis, if you will. So no, we haven't seen that, and it's really a relatively painless procedure. It's more annoying than it is painful. And so, yes, I think this is great. I would be careful on this in keloids. I don't think we have enough data yet to know, so I would just keep an open mind about that.
You know, there is a question coming in specifically about swelling. I'll underscore that with this technology, swelling is very minimal. But Emil, can you comment on your ways to sort of combat swelling? Sometimes as dermatologists, we see people who are dermatographic. You literally scratch their arm, or the equivalent is using the roller over their arm, and they swell. So, you know, I have no problem telling patients that know that they have a history of swelling with any procedure, particularly rolling procedures, to take a non-sedating antihistamine ahead of time, a day or two before, and that day as well. What are your thoughts?
I think that's a great idea if there's a known history of dermatographism. Unfortunately, we don't know a lot of times. I do think as as Dr. Arash Motazov said, I use a cryo unit with it. I keep people cool. I think it's very important. And I also use ice, adjunctive ice as well. And I don't freeze the skin. I go off and on when I use this because I think keeping people cool, it helps prevent swelling and it makes it a much more comfortable procedure. It is also distracting. So I think it's a great adjunct.
My patients don't have swelling or downtime by using the cryo. Yeah.
Dr. Bloom, what are your...
I actually like to use the cryo, the chiller over using ice when possible. I think it's more comfortable, and you have a continuous flow of air that's chilling the skin rather than this kind of on and off feeling with ice. You know, obviously, you know, sometimes we'll use ice packs if we need to, but typically just chilling the skin makes a huge difference in comfort. And also I agree with the amount of erythema and swelling that you see after the treatment. In terms of acne, I have not seen any acne flares with these treatments. And certainly we do see acne flares when we use some of the deeper non-ablative wavelengths, such as the 1550 or the 1540. And I really have not seen that with this.
So one more question before we turn things over to Dr. Tangeti. Specifically, there's a question coming in about alternatives to hydroquinone that you may use in terms of pre-treatment. So we use cysteamine, 5% cysteamine, which is Cispira, the brand name. It's marketed by Sente. And you can use that ahead of time to pre-treat some of these people. I typically don't incorporate topical steroids or hydroquinone that much. Because I find that oftentimes patients have been on hydroquinone for a long period of time. And I've seen a couple cases of paradoxical exogenous ochronosis. Does anybody want to comment on their realm of what they do in combination for people who really have a lot of pigment and you're using this ultra in combination with something like tranexamic acid? What else do you do for patients at home when their little vial is not going to take them more than a couple days after treatment?
I mean, I'll speak up. I mean, you know, we should look at the data. The data would indicate that retinoids are a very useful adjunct to treating PIH, and especially tazarotene, treating melasma, treating photo damage. And so I typically use retinoids. I particularly like the new Eraslo, which is a new version of tazarotene that has emollients and humectants cooked right in it, and it works very nicely. But again, retinoids are really a foundation for treating all these conditions and really normalize differentiation and often prevents over repigmentation as long as you don't get too much irritation.
Great. So
can I make a comment, Joel?
Sure.
I really like to use Definage, which is an alternative to a retinoid, because it's really been shown that it does stimulate new epidermis that looks very fresh. And it's the same kind of an idea because you're getting rid of some of the old keratinocytes that are heavily pigmented. And it's been really great because a lot of people can't tolerate retinoids, or it may complicate. You have to tell them to go off of it and then go back on it. And with this, you don't really have to do that. So I've enjoyed that.
So it's a pleasure to turn things over to Dr. Tangeti, who practices in Sacramento. Dr. Tangeti has been very active in the world of lasers for many years in ASLMS and has taught so many of us lasers and is really the go-to person when it comes to how something is used and what are the safe settings. And really his work with a lot of the histology that he's going to be discussing with different modalities has been really groundbreaking and helpful to understand how things work. So Emil, take things over.
Yeah, these are all based upon presentations that we did at last year's ASLMS meeting that probably no one ever saw because no one ever really publicized it. But again, we took this device, and Jim Childs, who was there, called me and said, let's get some histology. So we did some histologies ex vivo, and also he did some previously in vivo. And these right here are some of the in vivo histologies that he did with the maximum setting. And this is at 20 millijoules. This is a 200 micron spot on the left, and the larger one, 350 microns on the right. And what you can see, even with these maximum settings, you see an epidermis that's been damaged, it's been dehydrated. So what differentiates this from, say, a CO2 is you might even have a low energy CO2. You would ablate the epidermis and wound the dermis. This dehydrates, it wounds the epidermis and also wounds the dermis down to about 150 to 200 microns. And again, this is at the maximum setting. The lower settings do this less incrementally, as we'll go to the second. On the right-hand side is the larger spot that you could sometimes use in a stamping method. And this basically takes it out and basically evens it out over a larger 350 micron area. Again, similar histology with a dehydrated epidermis and a wounded papillary dermis down to about 100 microns. Next slide. Now, if you use it at the lower powers, 5 or 10 millijoules, that is indicated right here, what you see is more of a dehydrated epidermis. It minimizes the deeper dermal injury. You get about 60 to 70 microns of injury in the dermis, which is just superficial in the papillary dermis. You see a dehydrated epidermis, as you see in the top slide over here. With the larger tip, again, this just spreads it out. Early at about 500 millijoules, you see vacuolization at the dermal epidermal junction. You see some damage, but as you increase the energy, the epidermis becomes dehydrated and the damage goes a little deeper. What happens here is this damage in the epidermis creates a mend zone, M-E-N-D-S. And again, what it means is basically this damaged epidermis is balled up and taken out and extruded through the surface. And what you'll see is a little dot on the surface, and that is the mend zone, a little teeny dot. I like using the random method because then you just see the dots randomly rather than straight lines across, which looks a little funny. Again, this can be hidden with makeup. Even with the higher settings, 15 to 20 millijoules, again, very little downtime. The patients are a little red for a day or two. It's not big downtime. Next slide. So again, we did a study here, and what we did with this study is we started a little bit more gingerly. We started closer to 10 millijoules, which is the lower setting. As Bradley indicated, it's often a go-to lower setting or melasma setting. And then they went up incrementally. We went up incrementally in the study because we found we had very little morbidity, even with the higher settings. Typically, we did 5 passes, which gives us anywhere from 15 to 30%, depending on how many times you go over it. The thing that's remarkable is the discomfort. It's just more, as I said, more annoying than painful. It's like 2.9, but it's really not that painful. And if you look at your patients, they're not wincing. It's just kind of a little annoying. The Zimmer certainly helps by keeping the area cool. Most of the patients did not receive anesthetics, but you could use it. And I'll stop here for a second and say, if you're going to microneedle, we typically microneedle first. We definitely use a topical anesthetic because they need it. And then we use this right on top afterwards. Again, these people have erythema, typically lasting 1 to 2 days. But again, this is not a painful procedure. Next slide, please. So when we look at this, it was pretty obvious that the graders were looking at this, and they generally found the right before and afters with the 20 patients that we studied in here. And again, typically multiple treatments to get this kind of nice result. Next slide. So again, when we looked at things like pigment, and you looked at the grading of the patients that were treated, 19 faces, 3 décolletés, and again, so we have a number of patients that were treated here with this, and we could see here that most, virtually everyone got improved. And if you look at the graders judge this. Most of the patients were improved, much improved. Some got very much improved, and there were very few that had no change. So again, it's pigment that we're looking at, and the FDA indication is primarily pigment. Though, next slide, more treatments, more improvement with pigment. One treatment, you got a little improvement. It takes 2 to 3 where you start to see it. So again, I think you're going to have to just say, look, low downtime procedure. It's going to take multiple treatments to see the effects that we hope to see, not just 1 or 2. You set the expectation, you're going to get patients that are going to cooperate and be happy with the treatment. Next slide. Let's try this here. So again, if you looked at patients for photo damage, and again, what we see in the US, photo damage is number 1, 2, and 3, at least in my clinic. And with a series of treatments, you can see, again, looking at independent graders, most patients got improved, much improved, and some very much improved. Everyone had a change. And again, these are remarkable with the series of treatments. You can see pigment is improved, but so is the fine line, the texture, and also the solar elastosis. That's that cobbling that you see on the surface of the skin. Next slide. So again, let's just click on the slide if you can, and it'll just show this moving. If you click on the slide, you can see again, it's back and forth, one direction, then back and forth the other direction. You can see the patient is not grimacing, and as Bradley suggested, this has this cool roller that shoots appropriately, so you're not going to over or under treat. You move, it shoots, you stop, it stops. So again, this is very reassuring. It makes it a very nice treatment. Next slide. This is just more of the same. I think we could clip the slide because I think people get the idea. So again, after a series of treatments, you could see improvement in the pigment. You could also see improvement in the fine lines and wrinkles. I'm going to stop here for a minute also and say, you know, it was mentioned that you could use this for actinic keratosis. And again, some of my Australian colleagues actually gave me a nice little tip that when you have that severe actinic cheilitis, you can use this on the lip. And the lip is a very difficult thing. Hard using 5-fluorouracil, freezing is a swollen mess. This is a nice treatment for severe actinic cheilitis on the lips. And there's actually a CPT code for laser treatment. So anyway, next slide. Proceeding on with more patients on the other side of her face. Again, you could see a series of treatments, nice improvement in the photo damage, the crepiness, again, pink skin, looks great.
And it's really nice improvement here in this actinic cheilitis, as you said.
Right, and the other thing that you could also do, if you were to combine this patient in particular with RF microneedling, I don't have the Genius, I have another device, but I think the Genius is a terrific device. If you do them both together, same day, same session, you will get some significant tightening with this. And again, a relatively low downtime procedure. Next slide. Again, this is that patient, 4 treatments that we showed earlier. Nice improvement of pigment, fine lines, that solar elastosis, that crepiness on the sides of the face, perioral areas, nice improvement.
So, Emil, this is monotherapy with the Ultra. Are you using the static mode on some of these like macular seborrheic keratoses and these larger lentigos?
Yeah, often I go over, you know, a number of passes, 5, 6 to get, you know, that 20 to 30%. And then I will stamp some of those. Yes, with the larger spot. It seems to be helpful. This is a patient with melasma. Again, tricky, be careful, go slow, use cooling. You know, don't try to hit it out of the ballpark with the first shot. And use your adjunctive therapy. Again, another patient with photo damage after a series of 3 treatments. You can see it takes the sallowness out of the skin, makes the skin vibrant, makes the skin look healthy. Again, it takes kind of a boring look and makes a person look alive, and they look, and they know they look better. Next slide. Again, another picture, same thing. Again, I would urge you to consider the RF microneedling, the Genius with this, because I think you could get some significant tightening. You could see the quality and the color of her skin's improved. It's just, we could do better with the laxity. Next slide.
This is
the chest, again, tough area, décolleté. Nice improvement after a series of treatment. Next slide.
To treat with other devices.
Next slide. Sorry about that. Okay, let's go back. This is important. Okay, so this is RF microneedling. This is the Genius here, followed by fractional thulium. And again, this is the LaserMD. And again, these are all generic terms because this was for a CME talk. But you can see here immediately after the treatment with a combination of both, you can see they're a little red, a little swollen, 1 day, 3 days. Again, they could still function, a little swelling. I must say the Genius is a bit more aggressive than some of the other treatments we use with the other RF microneedling devices. You could turn the setting down a little bit. But again, you could see that the patients heal up, they can function with makeup. And so this has really been our go-to treatment by combining both, because patients want improvement of the laxity, but also the character of their skin. And we showed you very convincingly that the character of their skin, the surface is improved with the LaserMD alone. Next slide. This is someone with just one treatment with the Genius. And again, I think these were using very aggressive settings with the Genius because I have a hard time getting this good with my device. But again, this is probably a much more aggressive setting with the Genius where you'll get a little bit more swelling. So again, I think you can combine these and you can get some very nice results. So again, what our patients are looking for is they're looking for improvement. They don't want to be totally, out of commission. They want to be able to work. So again, using a treatment over multiple sessions has become our go-to way to keep people vital, to keep them in their work, to keep them in the family without the downtime. Quite frankly, I've seen that after a series of treatments, I do much better with this than some of the fractional aggressive settings we've seen with the other devices where we get a lot of downtime. I don't see a need for this. I see these patients are doing very well. Next slide. So that's it. Thank you.
I want to go back to just a couple things. That was great, Emil. So, first of all, with reference to the Genius and your indication about this, where this falls with other RF technology, this is RF microneedling, and the Genius is really a significant advance over some of the other technologies out there, including even the precursor, the Infinity. So first of all, the Genius is really this smart technology. It really senses if you're in good contact with the skin, and you can modulate your settings down or up, but what it really does is helps with that area under the curve to make sure that you're delivering effective power. We can go down to different depths. These are insulated needles, so it really protects the epidermis, and the active part is below the skin. And typically I'll do passes at 3 or 3.5 millimeters, and then 2.5 millimeters, and then 1.5 millimeters, and do 3 passes. And some of these patients with significant areas of these secondary smile lines and the accordion lines here do really well. We definitely see improvement in the jowls. We see some improvement in the elastosis and the solar elastosis of the neck. But another area that really shines is acne scars. And I think for all of those, if you combine it with the Ultra, then some of this patterning that you see here really helps sort of go away. You go over it, you sort of clean it up by sequential treatments with the Ultra. So we've had a good experience of doing that in our practice. We see less patterning, and people actually seem to recover nicely in terms of seeing a glow to their skin, decreased pigmentation, as well as overall improvement in some of the tone. Other people have that experience in combinations? Arash, what about you?
Yeah, so I do very high settings and aggressive treatments with Genius because I need it to get closer to surgery for my patient population. And I find that I always layer the LaceMD Ultra on top, and that my patients never have more than 1 to 2 days downtime. So, it just doesn't need to have a lot of downtime. And then, when layered, when done alone, there's going to be more of a recovery than the Ultra being on top.
And then, Emil, for the melasma patient right here, this is a really nice result here. I think one of the ways that we can help ensure that our patients don't get that much heat buildup, and at least my approach, is not only to use a Zimmer device during treatment, but when I'm specifically treating melasma, in addition to turning it down, I'll tend to do 2 passes, then switch to another region, then switch to another region, and then come back. You may argue that there's a little bit of swelling that sets in, but again, I think from a heating standpoint, and it doesn't take that long and the swelling is very minimal, it at least allows me to sort of cycle around. You just have to keep track of where you are and what direction that you're going, but at least it allows you to sort of keep the heat level down. What tips do you have for melasma and keeping heat down?
Well, it's going slow, adjunctive cooling. We use cold roller. We use icing. When the patient's doing one, the other side, they use a cold roller or ice bag on and off. So we use it all. And I think that all the suggestions you're hearing are very good. And we use adjunctive therapy, and just don't get too aggressive. That's all, because it can bite you. And so,
Brad, what about your New Yorkers? What do you do for them?
I think Dr. Tanghetti's point is really important. Melasma is not the time to try and knock it out of the park on a single treatment. If you're too aggressive, you increase your risk unnecessarily. Slow and steady wins the race. It's the last thing anyone wants to hear, but it's true. when it comes to melasma. And I also, we, you know, like I said before, we use the Zimmer chiller to cool the skin. There have been some studies that show that using a topical steroid for 3 days afterwards, after a laser treatment, can decrease the risk, or at least decrease inflammation in the skin. And so people who are incredibly high risk, you know, that's something to consider as well.
Well, I think you're absolutely right about the topical steroid. That is an adjunct that a lot of people don't realize. And you don't have to use a really strong topical steroid. You could use 1% hydrocortisone cream that works very nicely to inhibit melanocytic proliferation. You're absolutely right. And the other point I'd like to make is the Genius is the best studied RF microneedling device that there's ever been. Their histologies are absolutely outstanding. Their insulated needles actually work. There are a lot of companies that have RF microneedling devices where the insulation doesn't even work. So again, I have to compliment the work that Jim Childs and the people did at Lutronic in developing the Genius.
I so agree. I think Genius is really a special treatment for many of these people. Acne scars is one of those areas it really shines. So it's a pleasure to introduce Dr. Amy Taub. Amy is batting cleanup here because she has a lot of great stuff to talk about. She's been a guru for many years about really combination therapy. She has so many devices in her office. I always talk to her at meetings about all the things that she has, but she's been really involved with this whole topical laser-assisted drug delivery, and in particular, the development with Lutronic for some of the things that they've done with the different topical formulations, in particular the Keratosis, and those were great pictures that Arash showed. So Amy, take it from here.
Okay, thank you so much, Joel. All right, let's talk a little bit about Lutronic Ultra for hair health. So there have been 4 international studies regarding scalp revitalization with Ultra. And Ultra alone has actually shown significant improvements in scalp revitalization. Actually, 1927 has been shown to stimulate some inflammatory pathways that help to stimulate hair growth. But it also has been proven to show that you can get 5 to 7.5 times higher absorption of a topical that consisted of nanoliposomal products that were wrapped. In that study, Kerafactor was not used. It was a precursor that was still effective, but we have developed something further. Okay, next slide. So you see some histological scalp changes. 3 days, this is just to compare 3 days post microneedling and Kerafactor on the left, and here 3 days post nitrogen 27 and Kerafactor on the right, we really see a strong reepithelialization and some global inflammation, meaning that the whole skin is more markedly involved than with the microneedling. Next slide. So what is Kerafactor? Well, Kera is for keratin, factor is for growth factors. And so Kerafactor approaches hair loss from a different approach. Now, minoxidil helps to dilate blood vessels. And finasteride obviously works hormonally, and there's other things that work hormonally. And we have a lot of patients that are around that either have tried these and haven't improved, or have improved, but they're looking for something more. And so this particular product has 5 biomimetic human growth factors and 2 skin proteins that help with scalp revitalization, i.e. some vessel dilation. And they're unique and they are proprietary formulations. And each growth factor and skin protein is individually wrapped in a nanoliposome carrier for enhanced absorption. And the reason that's important is because liposomes are little, they're carriers for products, and they are absorbed more easily into a hydrophobic type of an environment because they're surrounded by oil, and we know that things go into the skin better with oil. And in addition, since they're nanoparticles, they absorb very easily. So go ahead into the next slide. And this is just to show that they actually do penetrate. So on the left, you can see that the same growth factors were applied without liposomes. And on the right, the growth factors were wrapped in the nanoliposomes, and they absorb into depth at the area of the bulge area, which is where many of the stem cells are inside the hair follicle. Many of the stem cells for the whole skin are actually in the hair follicle. And maybe many people don't realize that there's actually a separate transfollicular absorption, and it's different from the epidermal absorption. So where the growth factor receptors are that we care about for hair growth, they're in the hair follicle. Next slide. And so we know that PRP has been shown to have a lot of effects. It's a little bit controversial, but I think it's pretty much accepted now. But you're getting a bucket of, the good thing is you're getting the patient's own serum, right? So that is considered to be supernatural. But the problem is that PRP, which is from platelets, the growth factors are really focused on healing a wound. That's what they're there for. So there is certainly a lot of overlap between healing a wound and growing hair, but not as much overlap as we want. So we thought with the advent of the international ability to actually make growth factors that really wasn't available until about 5 or 6 years ago, that we could make these growth factors, but we could tailor it to hair growth and also have a higher concentration than what's found in PRP and have an off-the-shelf solution for that. Go ahead in the next slide. So the simple protocol is you treat the scalp with the ultra laser, you massage in the serum that has all the growth factors, and you can either do it once a month for 3 months, or typically we recommend every 2 weeks for 6 treatments, which really gets them in your office a lot. And it gives us 3 months to really to demonstrate some good hair growth. And we also recommend, we actually bundle a bunch of we bundle the 6 treatments usually with some take-home product, so that they're just given it and they're going to hopefully use it. Go ahead, next slide. And this is just to show one of these treatment sessions after 13 weeks, and you can see how much healthier the scalp hair looks. It's thicker and more vibrant. Next slide. And in the study that was done, you can see before that what happens when your hair miniaturizes or when it starts to fall out is a lot of the hairs become single hair per duct, and that's on the way to miniaturization. Then the hair gets smaller and smaller, and pretty soon it's going into a vellus hair. And what was shown after this is that not only you get 43% more double hairs after the 9 weeks in this particular patient. Next slide. And a really striking thing that's very noticeable is an increase in the hair shaft diameter, which in this particular patient was 64%. And that's why you see those much thicker hairs that look so much healthier. Next slide.
Well, we're going to start. I like to do it
Just
like this,
doing
like a key treatment. Keep going.
Sorry, it's not the greatest video.
Go all the way to the end and start again from the back. We want 2 passes because we're doing laser-assisted serum delivery. We don't want to. We're not trying to.
Okay, next slide. I was just to give you a little visual. Now, when we do the treatment, so really, I've gotten to be really fast and good at this. I have an assistant with me with a comb, and we kind of I mark out the area because sometimes you get confused where you are, like you're on the top of the scalp, you're on the side of the scalp. I mark it out with like a white pencil. I usually do a little bit of alcohol scrub to the scalp. It's critical that the scalp is dry, okay? Because we do not want to be actually burning a hair. If the hair is wet, it will absorb the laser energy and you'll actually fry the hair. So we do not want that because there's no way you're going to get, unless somebody's completely bald, you're going to be going over some hairs, and you don't want the hair, which is usually very devoid of water, to take up any of the energy. But you do have to, especially like for women, sometimes they have a lot of hair, but it's just thinner. And so you kind of have to go, I usually go about 1/2 to 1 centimeter apart and part the hair. And then my assistant holds it open, and then I just use the hair comb. I find that's faster, and I only need to do 2 passes. Once you've done the treatment, I tell the patient, don't wash their hair or dry it for at least until the next day. Stay out of the sun if you can. And you can sometimes see a little bit of shedding, because as we know, anytime there's any inflammation in the scalp, sometimes you can get a little bit of, of a telogen shift. So if that happens, which it doesn't happen to very many people, just tell them to sit tight. It will go away and all the hairs will start growing in.
Amy, can you just explain that a little bit more too?
Okay. So in general, we don't see a telogen shift. You know how sometimes when you start Rogaine or minoxidil, a lot of the hairs then will go into telogen, and people will experience a lot of hair fallout, and they get really upset because then there's a delay. And basically what it's doing is making the hair go through its cycle. So it's accelerating the cycle into telogen, and then all of them, a larger percentage of them, go into anagen. Now, typically that does not happen with this treatment. However, I'd say 1 out of 10 patients will experience an increased hair loss. And so you have to prepare them for that. But for the most part, we haven't seen it too much. And just tell them they're cycling through so that all the hair will come at, will really be more in the anagen cycle. There are some vasodilators in this, and so sometimes that can happen. Next slide. And here you can see in the Korean study, again, you can see more hair, and it's much thicker. And we find that sometimes the hairs come in more pigmented too. Next slide. And again, before and after, a 41% increase in diameter, and all those little red circles are dots where a hair is starting to peek out. Now, you may ask, how was this taken? I mean, it's so close up. They actually did tattoo the scalp with a fluorescent tattoo so it wouldn't show up. And so they could find the exact place where they were by, using an ultraviolet light and looking at the fluorescence. Okay, next slide. And here's another treatment, case 3. And then another slide. 38% more hairs. And another slide. 90% increase in diameter. And a bunch of new follicles seen. So obviously, if you have a whole new follicle, or if you have a follicle that's been laying dormant, you're not going to see a full hair at the end of 3 months. But hopefully you will either see some small things sprouting or, very miniature hairs that are usually not vellus. They're usually dark hairs. Next slide. Again, before and after. Next slide. And this one is 113% increase in diameter. Next slide. And so this was the summary. It was like a case series where the average increase in diameter was 77% and the average increase in revitalized hair was 50%. We keep trying to get these doctors to publish it, but I guess they're really busy, It's hard to get around to writing this up. Next slide. And this is some of Janine Downey's. I think everybody knows Janine. She's a well-known dermatologist who speaks a lot to the media, and she's really passionate about hair loss. And, African-American hair loss is very multifactorial and very difficult to treat. So we were all very excited when we started to see her early work. This is after only 1 treatment. Next slide. And this is just a really astounding result. Early days. Next slide. And here's 3 more before and afters. Of course, these aren't African Americans, but your typical males who want to get more coverage. And like PRP, you know, it's not like a hair transplant, but you get, you know, a significant amount of hair, more hair, and especially at this frontal area, that's a difficult area to get.
Amy, how do you decide between this and PRP, or do you sometimes do things in combination if you see this not really picking up as many areas of growth as you were hoping?
Well, I'm kind of an enthusiast for this treatment, you know, so I'm pretty excited about it. But I do tell patients, look, you know, PRP has been around for a lot longer, and it's been much more studied. If they're like the tried and true type of person, I tell them, you know, go for the PRP. And I know other people have good techniques, but I find it to be very painful for most patients. A lot of people do not want to get injected with needles, or I have patients coming to me who've had PRP and either want to maintain what they got and don't want to have injections again because it's painful. Also, this is less expensive than PRP, so that can be a factor. So I just, you know, sometimes it's like anything else. How do you decide to choose this laser versus that laser, especially if you think they're both good? In the consultation, I kind of feel the patient out. I tell them, we have all these choices. I tell them it's really hard to grow hair. We want to do as many things as we can up front to demonstrate that we can grow some hair, and then we can figure out what to do for maintenance. And, you know, they seem to be attracted to one thing versus another.
So some of these, in particular here, you see Janine, it looks like 12 treatments, 1 a week.
No, it's 6 treatments, 1 treatment every 2 weeks for 12 weeks.
So some of these were 12 treatments. I saw some were 6. How do you decide, and really what's your maintenance interval? There's a question coming in about maintenance interval.
I don't do 12 treatments. I do 2. I try to get people to do 1 treatment every 2 weeks for 12 weeks, 6 treatments. And then I tell them to come in at either 3 months or 6 months. I think what will happen is you see a little bit of fall off at 3 months. And so it also depends on how good they are with their home care. There's 2 products. One is the Kerafactor solution, which is in a dropper bottle. It's nothing like minoxidil. It's not greasy at all. It's water-based, and it doesn't smell. And most people really like it, actually. There's also a conditioner shampoo that makes it very easy for men, especially because they don't need much of the product, and they can just use that in the morning, and they like that because there's less maintenance. And I think the maintenance does make a difference, and I always tell them it's just the same as, this is kind of like food for your hair follicles, which need extra food because we're aging. And if you don't give them that extra food, they're going to start diminishing. It's like plants growing. So that, you know, that motivates them. And I just tell them, come in when you start to feel like there's been a little bit of loss. Ideally, at least once every 3 months, but they can try every 6 months as well. But I also tell everybody up front that this is not a permanent result, just like PRP is not a permanent result. So the next slide, another patient from Julie Winfield. And the next slide, this slide is kind of backwards. So if you look at the bottom right, that's the before. And then at 4 weeks, you see an improvement. And at 8 weeks, you see how, you know, the part has really gone from being widened to being pretty much normalized. Next slide. And this is one, I'm sorry, I apologize for not the greatest slide in the world, but I think you can see that she just has a lot more hair, and it's much more, it's just a better quality. Next slide. This lady said she lost all her hair in 1 week. She's a little bit loony, but she was really happy with this result. Next slide. And another slide just showing, again, this is typical female angiogenetic alopecia, where they start to get this widened part. And although she does have more color on the right, so that you have to kind of factor that in, I think you can clearly see that the part is narrowed. And that's all I had.
That's great stuff. So, you know, I think this is one of the differentiating features between Lutronic's technology and some of the others out there, is really the science and the data and the things that you showed us about these serum-assisted deliveries. and really the specificity that this has specifically for hair growth as opposed to wound healing. You know, we've talked a lot about some great stuff over the course of the hour and a half, and we're wrapping things up. And really, for people out there who have the Lace MD Ultra, I want to talk a little bit about that. But Arash, let's go back to you for a second, because you said that really your patients don't want any pain and they don't want any downtime. But you also said as a surgeon, you want to give maximal results with the Genius RF when you do the Genius and then do the Ultra over it. Talk to us a little bit about your approach and how you marry all those really tough concepts, because you know, the patient population you're seeing, how are you doing that?
Yeah, so with the combination total skin solution treatments, I find that if you use the cryo with it, then the pain is really low and the downtime is not much at all. So that's kind of been the...
With the Genius though, are you doing Pronox? Are you doing block? What are you doing?
Okay, so with the Genius, now that I have cryo, before cryo, yes, I would do Pronox and all these other kind of things, but now I do not. So now I do topical numbing cream, which is lidocaine tetracaine. So I leave that on for 40 minutes. Some patients take a Xanax if they have baseline anxiety, just to be relaxed. Most do not. And then we just use the cryo and do the strong Genius treatment, cryo with the Ultra. On patients who are pain averse, which is like 1 out of 10, I'll give them an injection in the mouth just to give a mental nerve block if I'm going to do like a Genius lift on the jawline a little bit stronger.
So we have a bunch of cryo 6 units in the office. We use them, but you know, first of all, I would say that along bony areas for the Genius, sometimes you need a little bit more, and the topical anesthetic for us doesn't seem to do it, and the cryo alone doesn't seem to do it. Sometimes I'll give these people a bit of a block infraorbitally, mentally, for that tolerance. The neck, they seem to do much better, but you know, we have Pronox on reserve. You know, what about downtime? Because you keep saying you give aggressive Genius treatments, and when we give aggressive treatments with Genius, we're oftentimes still seeing swelling for 3 or 4 days.
When I do them, usually in the total skin type of protocol with Genius and Ultra, with cryo, it's about 2 days. Okay. If I add in also doing it with FaceTite or AccuTite as a third layer, then they get swollen for 4 days.
All right. So, you know, we've heard some great tips as well. Dr. Tangeti really spoke about actinic cheilitis. I think that that's a wonderful pearl. You know, a lot of us have talked about how we use this for melasma to try to ensure low heat by doing a couple passes and then going to a different area, or using the Zimmer chiller, or doing icing in combination. And then some of the complementary things that you can do to gear up for it in terms of topical applications of either pigment correction products, cysteamine, hydrocortisone to inhibit the melanocytes, as well as retinoids, and then waiting a little bit and then resuming things afterwards and integrating the laser-assisted drug delivery. A lot of the questions now are really coming in, and I'm going to turn things to Dr. Bloom, is really how do you decide between Lace MD and keeping that, and I had that for a couple years, or the Ultra. And I will start out by saying that the Lace MD was 5 watts. The Ultra is 20 watts. So the Ultra is much more power that you can generate. It corrects it for you. It's a much quicker treatment. In general, I can treat the entire face in about 12 minutes and the neck in about 9 or 10 minutes. So this is really a major advance in terms of the overall power of this type of modality. And then in addition to being 4 times more powerful from 5 watts to 20 watts, the actual tip itself is 4 times the size, making treatments more quick. But Dr. Bloom has a lot of experience with other devices out there and how you decide what's going to fit best in your practice and what to use. I'm going to turn things over to Bradley.
No, thank you so much. So this is an interesting question. So there's nothing wrong with the Lace MD. The Lace MD works, and obviously we did some clinical trials and showed that, you know, it's certainly efficacious. The difference, and that jump to making this device more versatile, was that increase in the power, but also which allowed for you to do more aggressive treatments that could be done in much more quickly. But I think something that's also been very nice is the user interface change. which actually allows us to calculate the total energy being delivered, allows for, in my hands, a much more reproducible result. And I think that's what patients are looking for, or something that we can say, you can expect this kind of result after this many treatments, or this kind of result after a single treatment. And to do that, we really need to measure things. And that addition of this counter that allows us to continuously monitor the total energy being delivered adds not only a layer of safety, but that layer of predictability that I think is very important. There are other devices out there that will also have that will rely on pass number, and pass number can be somewhat imprecise based on a person's technique, whereas your total energy is your total energy. You can't change that, right? It is technique independent, so it's very predictable.
So Emil, Amy, Arash, can you comment, or Bradley, on the other topicals that we didn't really touch on, aside from tranexamic acid and the Keratosis? What about the one that contains vitamin C and A and resveratrol?
Well, vitamin C and resveratrol are obviously really potent antioxidants. And again, although vitamin C, there's a lot of products that contain vitamin C, it's always tough to get it really fresh. So certainly it is a great treatment, I would think, for post any kind of photo damage. And you could say the same about the resveratrol, whereas the retinol also is, it's basically retinol. It's not really retinol, but it's vitamin A. If you've ever seen, I'm blocking out his name, but the kind of inventor of microneedling, who, really touts vitamin A as being critical in generating the results that you can get. I think that we're just scratching. I don't even have a ton of experience using those. I think we're really scratching the surface of what we can consider in terms of what improvements we might get in the skin with some of these antioxidants and other products.
Great. I'm going to turn things back to, sorry, Emil, go ahead.
The data with a lot of these cosmeceuticals is sketchy. And so it's very difficult. I think we have tremendous data with topical retinoids. The prescriptive ones we know work, and they've been validated. The others we're dealing with a lot of difficulty because we don't have a lot of good data. One thing though that we do know is that when you damage the epidermis, and especially the epidermis, it generates just a load of cytokines and chemokines that do result in rejuvenation. So yes, you can use PRP, but by just damaging the epidermis, you generate a lot of these factors just in the whole injury. So there's every reason to use a device that does epidermal injury.
There is a comment that came in that Keratosis is allowing people to see improvement more quickly. And I just wanted to throw it out to everybody here. Have you seen that compared to PRP? And, really, what's your overall sort of advice to patients in terms of, if they're doing 6 treatments and then maintenance treatments, when do you tell them they should be starting to see improvement?
For definitely when the PRP treatments that I do, I usually tell them not to expect a result for almost 6 months. But with Keratosis, I find that even at 2 months, you can see a change, and that and I tell them their peak results is going to be around 6 months. I like them to do repeat treatments. I think both PRP and Keratosis, the results are going to wear off. So I like them to come in once every 6 months to do some kind of booster.
And Bradley and Emil, are you doing PRP and Keratosis alone, or how are you handling this?
I don't do the Keratosis, so I can't speak to it. We do PRP for certain things in the office, but I don't do the Keratosis.
I don't do this.
Okay, all right. And then Amy, you had a great experience doing that. I think you really have encouraged a lot of people to complement their practice with this, and I think that's really helpful. And again, an area where Lutronic has put the time and effort and expense into developing these topical formulations to use in conjunction with the most powerful thulium laser out there with the lowest cost tip, which is a fast and efficient treatment with very little discomfort. Again, my patients are usually 2 to 3 out of 10 and a day or two recovery, and you can complement it with Genius RF or the Spectra Q-Switch 532 and Q-Switch 1064 in my practice. So Dan Sullivan over at Lutronic has put a lot of work into tonight's seminar and really into managing so many different products. And I'm going to turn things back over to Dan so he can share his email and talk to us about ways that other people can pose questions.
That's great. Thanks so much, Dr. Cohen. Really appreciate the kind words. Thank you very much for being a wonderful moderator this evening, and a million thank yous to our wonderful panelists as well. We just I think had some great conversation, lots of great questions from the crowd. Most importantly, I want to thank everyone for attending this evening. We had a record turnout, and people were stuck around till the end because they wanted to hear some good stuff, ask questions, and learn new things. So we're all about education here at Lutronic. If you didn't get a question answered, you need some more information or need something specified, feel free to send me an email there on the screen, dsullivan@lutronic-usa.com. Again, my name's Dan. Please do follow us on Twitter as well as all of our social media outlets. Keep in touch. Let us know if you need anything. Have a wonderful evening, and we'll talk to you next time. Thanks a lot. Bye-bye.
Bye.
Thank you.